I'm recording everything, blah, blah, blah. Okay, so blood pressure, okay? We figured out that there are few major factors that influence the blood pressure, right? The cardiac output and the peripheral resistance. Remember that? So if we want to write it down, we can say that blood pressure equals cardiac output multiplied by peripheral resistance. Does that make sense to you? Because if you increase cardiac output, you can increase blood pressure. If you increase peripheral resistance, you can increase that too. Huh? Sorry for my handwriting, it's cardiac output. It's cardiac output. Okay? Does that make sense? Now, what else? Okay, so cardiac output. Which organ is responsible for cardiac output? Heart, right? Heart pumps. Peripheral resistance is the function of blood vessels. Which blood vessels do you think will play the major role in alterations of peripheral resistance? Arteries, right, but can you be more specific? Arteries closest to the heart, wait. Arteries closest to the heart are which ones? Like aorta. What will happen if aorta constricts? We're gonna die, right? So, which arteries, how they regulate blood pressure? By doing what? Dilate and constrict. Arteries that are closest to the heart, which type of arteries they belong to? Elastic. Can they really change the diameter? Like, they have they have very little, if any, vasomotor response. So which arteries will contribute the most to the regulation of the blood pressure? Muscular and arterioles. Does that make sense? Does that make sense? The vessels that can produce vasomotor response, that can constrict and dilate. Does that make sense? Another thing that we didn't discuss yet is the link between the blood volume and the blood pressure. So if you increase blood volume, how it's going to alter the blood pressure? If you increase the blood volume, yeah, it's going to go up. Does that make sense? Because you have more fluid in the same pipes. Is that good enough? So that's the third way to manage the blood pressure, to alter the blood volume, okay? And that is done by kidneys. Does it make sense? Say if you have too much of the intracellular fluid, a lot, high blood pressure, okay, you can try and pee out some of that fluid, okay, decrease the volume, decrease the blood pressure. Does that make sense? It takes a while though. So short-term mechanisms, almost immediate mechanisms, are mechanisms via heart and blood vessels. You can appreciate that when you get all excited or when you exercise. It is your heart that starts to pump faster and stronger. It is your blood vessels that dilate in muscles and constrict pretty much everywhere else to redirect the blood. Does that make sense? Okay? Kidneys take a while. It takes a while to alter the volume of the blood. Right? So regulation of the responses can be neural, directly through sympathetic or parasympathetic nerves. It can be hormonal, it can be chemical. Does that make sense? let's take a glance at this flowchart. There are two, we're going to focus mostly on the mechanisms of blood pressure increase, because first, it is important from the pathological standpoint, why we develop hypertension. And second, increased blood pressure is usually associated with mobilization of the body, like the exercise or fight or flight reaction. Okay, so exercise. You start to breathe harder, respiratory pump is getting activated. And since you exercise, your muscles start to contract, so muscular pump is getting activated. These two things, are they clear? Increased function of respiratory pump and muscular pump. And also, veins become slightly constricted due to the sympathetic stimulation. All of it increases the amount of blood that comes back from the veins into the heart. Does that make sense? So increased venous return means that end diastolic volume is going up. Does that make sense? So amount of blood that fills up the heart at the end of diastole goes up. That increases stroke volume and increases cardiac output. Does that make sense? Now, let's say you have a drop of blood pressure. Why can it happen? Why you can have the drop in the blood pressure? That losing blood, yeah. So you lost some blood. That will increase, so just drop in the blood pressure will be sensed by centers in the medulla oblongata. We talked about them, cardioinhibitory, cardioacceleratory. So decreased blood pressure will stimulate sympathetic activity, which means cardioacceleratory, and decreased parasympathetic, right? Now, increased sympathetic activity means, first, contractility will go up, so heart will start pump stronger, okay? And also, it will release epinephrine in the blood. So heart will not only pump stronger, it will pump faster. Does that make sense? So when heart pumps stronger and contractility increases, the end systolic volume, amount of blood that is left in the heart after the systole, after the contraction, end systolic volume will decrease. Lower end systolic volume corresponds to the higher stroke volume. All of it together will contribute to the increased cardiac output. What I like about the flow charts like this is that they allow to present things in step-by-step fashion. What I don't like about the charts like this is that they present things in step-by-step fashion. Because essentially what happens, everything happens at once. Say when you exercise, okay, when you're losing blood, usually not just, stabbing yourself and looking for it to flow down. Say it's a fight. You already have sympathetic stimulation going on. Your heart rate is already up. Your vessels are constricted, okay? Your heart is beating faster and stronger. Does that make sense? So all of these things, in fact, might as well happen all at the same time. Increased venous return, increased contractility, increased heart rate, they all will contribute to the elevation of the blood pressure. Does that make sense? So what are the ways to regulate the blood pressure? One of these things we use as the example of negative feedback when we just start the classes in AP1. So let's say your blood pressure goes down. Systemic blood pressure goes down. What is the blood pressure? How would you define blood pressure? It's some sort of a force. Huh? well, resistance is the resistance, but blood pressure is produced because of the resistance to flow. But what it is, pressure, what does it press on? The vessels, the walls of the vessels, right? And they kind of sort of stretched a little bit. So when blood pressure goes down, that stretch, does it increase or decrease? It goes down. Mechanoreceptors that are located in two major places, the carotid sinuses here and the aortic arch, they sense that decreased stretch. Does that make sense? Okay, they sense the decreased stretch, and they immediately send a signal to the medulla oblongata. Does that make sense? Now, let's figure out if pressure goes down, which center will be stimulated, cardioacceleratory or cardioinhibitory? If acceleratory, so heart starts to work harder. Does that make sense? Cardioacceleratory center goes up. Does that make sense? Are you okay? If blood pressure goes up, then which center is going to be stimulated? Cardioinhibitory. Which one of them is sympathetic and which one of them is parasympathetic? Yes, cardioacceleratory center is sympathetic. Cardioinhibitory is parasympathetic. Okay. Now, based on the name of that center, what's going to happen to the heart? How it's going to beat? Faster, slower, stronger, weaker? Cardioacceleratory will make it beating faster and stronger. How will it change the blood pressure? It will increase it. There you go. Does that make sense? So that will essentially, cardioacceleratory center will increase cardiac output. Another way, I want to put it down here. Remember that blood pressure is proportional to cardiac output and peripheral resistance. Can you change peripheral resistance? Generally. Come on. Peripheral resistance. Okay. How can you do that? Dilation and constriction, right? Say it. Well, it's peripheral. It's a resistance, right? It's a resistance of vessels to the flow. If you make vessel huge, resistance is going to be low, high. Low. If you make the vessel really, really tiny, resistance will go up. Does that make sense? So, another center that is also in the medulla is, where's my pen? Vasomotor center. Okay? Now, vasomotor center is purely sympathetic. So, if vasomotor center is stimulated, what's going to happen to the blood vessels? They're going to constrict, and blood pressure will go up. Does that make sense? Now, if vasomotor center is inhibited, let's write it down, shall we? So, blood pressure goes up. Vasomotor center, is it inhibited or stimulated? If blood pressure goes up, inhibited, vasomotor center inhibited, wait a minute, vasomotor center inhibited, vessel diameter increases. If blood pressure goes down, vasomotor center stimulated, diameter of the vessel goes down. Does that make sense? When diameter is low, blood pressure goes up. When diameter is big, blood pressure goes down. Okay? That is the nervous stimulation. That's what we call a baroreceptor reflex. Do you understand why this is a reflex? So you have a sensory input, which is what? Blood pressure, yeah. Sensation of a blood pressure by those mechanoreceptors. Then you have that input going into the, which part of the brain? Medulla, which essentially generates the response to alterations in the blood pressure. And then you have response, which is constriction or dilation, stimulation, It's partially vagal. Okay, vagus nerve will regulate the heart. Okay, not the blood vessels though. Okay, does that make sense? And can anyone tell me what are the only two effectors of the nervous system? Muscles and glands. So I ain't see any glands involved, but there's a bunch of muscles. Cardiac muscle, right? And smooth muscles of the blood vessels. So if classic reflex arch, sensory input, integration, motor output. Does that make sense? So please understand how it works. Understand the roles of those centers. Okay? Chemoreceptors. They detect the levels of oxygen, CO2, or level of pH. When cells become very metabolically active, what they use? Which chemical? When they become oxygen. They use oxygen. So oxygen levels in metabolically active tissues should be, since oxygen is used, lower. When they use oxygen for respiration, what do they produce? Carbon dioxide. So carbon dioxide levels in metabolically active tissues should be high. And especially if oxygen is low, well, okay, CO2, when it's dissolved in water, which is abundant in the body, what does it produce? Acid or base? Acid. Produces acid. So metabolically active tissues are oxygen poor, CO2 rich, and acidic. Does that make sense? Metabolically active tissues, do they require increased blood flow or decreased blood flow? Like I ate all the stuff, I completely filled up the crapper, and then I tell, oh no, don't bring me any fresh food, and the crapper can sit here in the room for like 2 weeks, right? Metabolically active tissue required increased blood flow to remove all the waste, okay, and deliver nutrients, deliver oxygen. So lower oxygen, higher CO2, I should circle it. Lower oxygen, higher CO2, or lower pH, which means acid, okay, when these guys are sensed by chemoreceptors, they stimulate increased cardiac output, right? And they stimulate. Now this is the funny thing. So systemically, they stimulate vasoconstriction, but there also will be a local regulation, which we're going to talk about. Let's say when you exercise, what happens to your heart rate? Goes up, right? And contractility goes up. What happens to the blood vessel diameter? This is funny. How your skin look like? Red, right? So they dilate it because you need to drop off the blood, the heat. What about blood flow to the muscles? What do you think when you exercise? What do you think? It goes up, yeah. But everything else, pretty much all other blood vessels are constricted. So overall, it's going to be constriction. But locally, it can be dilation. Does that make sense or not? Yes. Yes. I probably confused you a little. Not that they don't need a lot of oxygen. Then they used it all. So now it is low. But they really need a lot of oxygen. But they use it up. Does that make sense? Okay? So CO2, lower pH, or oxygen, the lower oxygen, they will all increase blood pressure. Okay? To restore the chemistry of the body, restore the chemistry of the extracellular fluid. Does that make sense? Hormonal regulation. You see, I even did the color coding. Very proud of myself. Epinephrine, mostly. Okay. Epinephrine increases blood pressure by increasing contractility of the heart, increasing heart rate, and causing vasoconstriction. Okay. And we will just, when people have anaphylactic shock, we will discuss how EpiPen helps to overcome the physiological consequences of anaphylactic shock. Okay. Angiotensin II is another interesting mechanism. We talked about it briefly. Remember when we talked about endocrine system, we mentioned renin, angiotensin, aldosterone? Remember? So renin is produced by the kidneys, and it stimulates the entire chain of events that ends up in production of aldosterone, right? What does aldosterone do? Does anyone remember? It increases the retention of something, sodium and therefore water. So it increases blood volume, right? Antidiuretic hormone does the same. But you can imagine that retaining water is the long-term response. In the short term, both angiotensin and antidiuretic hormone are vasoconstrictors. Does that make sense? They're produced in response to the lowered blood pressure and cause vasoconstriction. Finally, atrial natriuretic peptide. This is the long-term regulation. Actually, it responds to the high blood pressure produced by the atria of the heart, okay, and it increases the excretion of sodium, therefore increases excretion of water, reduces blood volume, and reduces the blood pressure. So those are four major hormones that we're gonna talk about: epinephrine, norepinephrine, angiotensin, antidiuretic hormone, and atrial natriuretic peptide. Question? We're good? Hypothalamus. When I say hypothalamus, you have to appreciate it's sort of, should I say, like partially conscious increase of blood pressure? Because when you're stressed, the stress signal is perceived by hypothalamus. Among other parts of the brain, it is perceived by hypothalamus. And the hypothalamus directly commands medulla oblongata to increase the blood pressure. So it's a typical sympathetic, directly sympathetic regulation. Okay. So again, before we move on, I want to mention this is the short-term controls. When you when you start exercising, we can, if we have sphygmomanometer and we have some time today, I need to check if we have it. We can try and do that. We can measure the blood pressure at rest, and then you can do like, I don't know, 20 squats, and we can measure your blood pressure after that. After the squats, blood pressure will go up. Does that make sense? So this is the short-term regulation. What about the long-term? For long-term regulation, it's kidneys. There are two mechanisms. One is direct. And direct mechanism is extremely simple. I described it here. Now, try to imagine, sometimes closing your eyes may help. Try to imagine that your blood volume increases. What happens to the blood flow through the kidneys? It increases. If you increase the flow through the filter, what's going to happen to the volume of filtrate? It's going to go up too. The more you drink, the more you pee. That's it. That's a direct mechanism of regulating blood pressure. Does that make sense? That's it. Is that understood? You increase the blood volume, you directly increase the amount of urine that you produce. Right? And that brings back blood volume to normal. If you decrease the blood volume, you decrease the amount of urine that you produce, and that also brings blood volume to normal. That's direct. Indirect mechanism. That's renin. And I understand that this flowchart can scare the living daylights out of anyone. Now, the sequence is pretty simple. Low blood pressure. Low blood pressure. In the kidneys, it is sensed by so-called glomerular cells. And glomerular cells, they produce renin. Renin stimulates the conversion of angiotensinogen into the angiotensin 1. Angiotensin 1 stimulates the conversion, it is converted into the angiotensin 2. Does that make sense? Angiotensin 2 stimulates aldosterone production. Do you follow me? Aldosterone stimulates what? Retention of sodium in water, yes. So aldosterone stimulates sodium retention, water retention, increased blood volume. Increased blood volume means increased blood pressure. Does that make sense? Okay, cool. Angiotensin 2 has another effect. It constricts the blood vessels. Does that make sense? Actually, the picture is a little bit more involved, and we're going to chat about it. Not only this, look at effects of angiotensin 2. Vasoconstriction, okay? Aldosterone stimulation. But it also acts on the pituitary and stimulates antidiuretic hormone. And what is interesting, angiotensin 2 stimulates thirst. When your blood pressure is low, you want to drink. You're thirsty. Okay? Do you see? Do you get the main idea of indirect mechanism? Renin, two different angiotensins that stimulate, angiotensin 2 stimulate aldosterone. Aldosterone increases water retention. It also stimulates, angiotensin stimulates antidiuretic hormone, which stimulates water retention. And on top of that, angiotensin increases vasoconstriction. Right? Good enough? Now, interesting thing. Have you heard about ACE inhibitors? So ACE is angiotensin converting enzyme. It's a key element in all this renin-angiotensin-aldosterone system in the RAS. ACE inhibitors were first isolated, well, the precursors were isolated from the venom of South American viper, the venomous snake. Okay? And scientists, Cushman and Andretti, you don't have to remember the names, don't worry. They studied the structure of the inhibitor and developed the drug that we now know as captopril. It was the first ACE inhibitor. Bless you, the drug that effectively treated hypertension. Does that make sense? Because it inhibited the entire renin-angiotensin-aldosterone system and decreased the blood pressure. That makes sense. Now, the interesting thing, I'm not talking about that awful South American pit viper, but as far as I understand, there are venomous snakes, and there are vipers in the U.S. All right. So one of the first symptoms of the viper bite is, what do you think? Blood pressure goes down immediately. One of the recommendations, I mean, you're not treating the patient, you need to bring patient to the hospital anyway, but to keep the patient going, one of the things to do, if you have nothing else, give them some coffee. It will increase the blood pressure temporarily and keep them up and running at least those 15 minutes that you rush them to the hospital. Does that make sense? Coffee can help just to, because if blood pressure falls too low, we'll discuss, it's going to cause the shock. Okay? Does that make sense? Just a little clinical link here. So that's kind of a summary, how you can control the blood pressure. There's a lot of stuff. And I understand that it's, as I mentioned, I like those flow charts and I don't like those flow charts for the same quality. Okay? So let's see what can increase the blood pressure, increase the body size. Does that make sense? Because you increase the length of the blood vessels. Right? Everybody understands that? Dehydration. When blood becomes really viscous, it increases the peripheral resistance and increases blood pressure. Increased vasoconstriction can be due to the hormones, chemicals, nervous stimulation. Also increases peripheral resistance. You keeping up? Now, what about other mechanisms? Okay. Exercise or trauma. Increased CO2 as the result of exercise, decreased blood pH and decreased oxygen, okay, by chemoreceptors will stimulate vasomotor and cardioacceleratory centers, increasing blood pressure. Okay, vasomotor centers will increase peripheral resistance, cardioacceleratory will increase cardiac output. Does that make sense? Okay. Fluid loss. What Hunter suggested, blood loss due to the wound, for instance. Blood loss, lower blood volume, lower blood pressure. If you cannot compensate right now, your heart rate will go up, and blood vessels will become constricted. Does that make sense? Atrial natriuretic peptide, if its levels are decreased, then sodium will remain in the kidneys. It will increase the blood volume. Okay? And finally, during the exercise, muscular and respiratory pump will increase venous return and increase the stroke volume. Okay, now, when you look at this, when you look at the regulation of the blood pressure, you have to think about this. Blood pressure is regulated by negative feedback. Okay? You keeping up with me? So if blood pressure goes down, what's the ultimate goal? To kick it up. How can you kick it up? What are the 3 ways? You can increase the cardiac output. Either squeeze harder or increase frequency, heart rate. That's number 1. What's number 2? Huh? Peripheral resistance. You can constrict the blood vessels. What's number 3? Blood volume. Does that make sense? You can start breaking it down further. For instance, how can you increase the blood volume? There are 2 ways. Drink, that's 1. You can consume fluids, or you can stop peeing. Okay, increase retention. Does that make sense? How can you increase the cardiac output? Well, we figure it out. Okay, how can you increase the cardiac output, stroke volume, or frequency? How can you increase stroke volume? Increase venous return, increase EDV, or decrease end-systolic volume. So either bring more blood in or squeeze more out. Does that make sense? So if you keep thinking in these terms, it makes a lot of sense, the responses that you produce to the certain things. I mean, can you increase blood pressure by dehydrating? Sure, but I don't think it's a viable option, really. Okay? So those 3, peripheral resistance, cardiac output, and blood volume, are the main mechanisms of the blood pressure regulation. Pressure and vital signs. Vital signs: pulse, blood pressure, respiratory rate, body temperature. How we measure pulse? It's the arteries that expand and recoil, we usually try to press the artery against something hard, like a bone, okay, or muscle. So these are the major pressure points. We can take pressure. The carotid is convenient in the neck, but there's not a lot of bones. Okay. The radial artery is at the wrist. Those are the most common. Okay. Systemic blood pressure. I feel like a dinosaur when I say it is measured using sphygmomanometer. Well, I mean, it is measured using sphygmomanometer in the hospital, okay? But come on, you go to any pharmacy and for $60 you can buy the electronic thing. And it's just as good, really. What I saw recently blew my mind completely. I brought my son to the doctor's appointment, and pretty much they put a cuff on him, and they put him on like a gigantic platform. It measured his height, his weight, his pulse, the cuff measured pulse and the blood pressure, and via Bluetooth, it all went in the computer right away. It was awesome. Now, you can still do the old style, and it's really simple. So sphygmomanometer, and I didn't manage to pull out one out. We can try and do it later. So it's a cuff. You need a cuff. You need the pump. You need the stethoscope. Okay. So put the cuff around the artery. Usually, the closer to the heart, the better. I told you last week the ideal place is the neck. Okay. It's perfect, right? You pump the cuff and the patient is dead, suffocates in a few minutes. So that's why we don't use neck, we use the upper arm. That's close enough. So it's going to be brachial artery right here. You have to pump it high. How high? What should be the upper, should you pump it to 200 or 180 or 140 or 160? 180 wouldn't work? So it has to be higher than systolic, right? You have to pump higher than systolic blood pressure. Does that make sense? So when you pump to the upper limit, okay, you completely temporarily block the blood flow through the artery. Does that make sense? And then you start to release the pressure. And at the same time, you put the stethoscope over the brachial artery into the antecubital region. And you listen to so-called Korotkoff sounds. It's pretty much beating, a pulse. When you start to hear a pulse, it means that you crossed the systolic blood pressure threshold. Does that make sense? And when the pressure that you exert on the artery goes lower than the diastolic, Korotkoff sounds disappear. So you notice the moment when they appear, and you notice the moment when they disappear. The first is the systolic, the second is the diastolic. Yeah, it's systolic and diastolic, yeah. Okay? Does that make sense? Yeah. Oh, you mean, so what Rebecca refers to, so this manometer is a liquid manometer. But usually it's not a liquid, it's an arrow. So you can see it goes smoothly, and when it hits the systolic pressure, it starts to jump. It jumps, and then when it hits the diastolic pressure, it again goes smoothly. It's not as accurate. But it gives you good perception. Again, if you want to tell 180 over 110 versus normal, that'll help. Does that make sense? Again, we can't beat the machines. Hypertension. First of all, it's a horrible topic. First of all, blood pressure changes. You exercise, it goes up. You stand up, it changes in different parts of the body. Like if you lie down and you immediately stand up, you have orthostatic changes in the blood pressure, your blood pressure in the head goes down. Does that make sense? So it changes all the time. It's different between men and women, old and young, more, less, fit, and so on and so forth. Okay? Now, the current idea is that normal is 120 over 80 and lower. Okay? Let's just stick with that, and then I will cause even more confusion. Let's just stick with it. 120 over 80 is normal. Now look, this is more of a, for you to understand the clinical implications, what we talk about. So if blood pressure is above that, systolic between 120 and 140, and diastolic between 80 and 90. It is considered pre-hypertension. Okay? It is not horrible yet, but it kind of a clinical sign of the oncoming disease, of the developing hypertension. It is often found in patients with diabetes or obesity. The problem with increased blood pressure is that human vessels aren't hoses. They consist of cells that can change. And in response to increased blood pressure, vessels start to remodel. And remodeling often goes hand in hand with conditions like endothelial dysfunction, which means cells become less dilatable, and atherosclerosis. Does that make sense? So pre-hypertension increases your risk for developing atherosclerosis. Also, pre-hypertension or elevated blood pressure increases after load, which means your heart has to pump against the higher resistance. Does that make sense? It has to pump in a circuit with a higher resistance. Does that make sense? Think about this. Which means, in order to maintain the same cardiac output, cardiac muscle has to work harder, which means cardiac muscle will start to hypertrophy. Remember we talked about ventricular hypertrophy, the myocardial hypertrophy? Remember? No? If no, then just say no. If you don't remember, say no, because I don't know what's going on in your head. Huh? Okay. Good. Thank you. Really, thank you. Think about left ventricle. It pumps in the systemic circuit. If you increase pressure in the systemic circuit, is it harder to pump or easier? Harder, right? You have to pump against that pressure. So in order to maintain the same cardiac output, what will happen to the muscle of the left ventricle? I mean, size-wise. It will overwork and will grow at the expense of what? The volume of the ventricle, right? Muscle will become thicker, but ventricle will actually become smaller. So that will be myocardial hypertrophy. Does that make sense? Let's be honest, systemic circuit is kind of, I don't want to say designed, but it has high resistance, higher blood pressure. So those vessels are hard and tough and rough. If for some reason hypertension develops in the pulmonary circuit, primary pulmonary hypertension ends with a death in about 2 years. It's untreatable disease, which leads to the right side hypertrophy, remodeling of the blood vessels in the lungs, or pulmonary circuit, and inevitably death of the heart failure. There are no treatments, no drug treatments whatsoever. Congestive heart failure, which leads to death. So right side failure is much worse. Does that make sense? Okay, it's really a big deal. So when blood pressure goes above 140 systolic, 90 diastolic, the patient's hypertensive. We've already discussed what can happen, atherosclerosis, endothelial dysfunction, cardiomyopathy, stroke. Stroke either because of the atherosclerosis or it can be hemorrhagic stroke. Here's what happens. When blood pressure goes up, blood vessels, in response, start to change the structure. And surprisingly, in some cases, fragments of the blood vessel become thin. They start to bulge. Does anyone know how this bulge is called? Have you heard the word aneurysm? patient can develop the aneurysm of the artery in the brain, okay, and can live with it for years. But then if the blood pressure spikes, the aneurysm can rupture and the blood will flow into the brain and it's going to be a hemorrhagic stroke. It's bad. I know a person who actually survived it and recovered almost fully. It took her years, like years. It's rare, yeah. It's very rare because it's a massive blood loss and it affects a huge portion of the brain. Okay. So hypertension is bad. What leads to hypertension? Combination of factors. Lifestyle. Salt, smoking, alcohol consumption, obesity, hypercholesterolemia, diabetes, genetics, a lot of it. Okay, genetics contributes to high blood pressure. You can find a person who's otherwise completely healthy but has family hypertension. Yes. Occlusion is the blockage. Hypertension is just high pressure in the blood vessels. Imagine that you connected the industrial water pump to your house water system. One day or another, the pipe's gonna blow. Does that make sense? It's uncurable disease. It can be controlled, of course. There are plenty of drugs. By changing the lifestyle, it can help a lot. Now, secondary hypertension is when hypertension is the consequence of something. Like if there is a kidney failure, hypertension will be a consequence. If there is hyperthyroidism, hypertension will be a consequence of hyperthyroidism. Does that make sense? Now, I told you it's not a confusion, just to give you a thought. American College of Cardiology, or whatever the association is, they recently issued a statement that says there is no safe blood pressure. I mean, 120 by 80 is good, but 110 by 70 is even better. And like 100 by 75 is absolutely awesome. So they suggest that lower blood pressure is associated with the higher longevity. Does that make sense? So then they say another thing that I don't totally agree with. We have to put people on statins and blood pressure lower medications even if they have 120 by 80. I'm not totally fine with that. Okay, but the idea is if you can lower the blood pressure, your blood pressure, just by lifestyle changes, do so. You're going to be better off. Okay, does that make sense? One of the studies actually, and I'd be honest, I like nutritional studies, and I like nutritional studies that fit my lifestyle more than studies that don't. Okay, so that one does. It suggests that consumption of whole milk dairy decreases the blood pressure. I'm all for it. More yogurt, more milk. Okay. I don't read studies about beer. I don't want to. Hypertension, low blood pressure, generally is not considered a risk factor. Huh? We don't know. We have no idea why dairy can decrease the blood pressure. Really, we have no clue. Just a big association. It was a big study. It wasn't like 10 people. Hypertension, 90 over 60. Not a concern, although people may doze off. I have some family members that have low blood pressure, and it's funny because sometimes they become groggy and just want to sleep. Okay. it's, again, it's not a concern. If blood pressure falls to like 50/30, you're pretty much boned. This pressure has to be elevated because blood flow to the organs becomes too low. But 90/60 is fine. There was some weird study that suggested that hypotension in middle age is associated with hypertension in old age, but I found it only once, that study. So I mean, there was no follow-up. So generally having low blood pressure is good. Okay. Orthostatic hypotension, when you stand up and you have lightheaded. Huh? Yep. Blood pressure, the blood flow to the brain drops because blood pressure drops. Okay. And you feel dizzy for a second. Okay. Chronic hypertension, when in Addison's, right? Opposite of Cushing's, hypothyroid, or, and there's a poor nutrition. People usually are not active in this case. And acute hypertension, that's circulatory shock. Now, let's see what can cause hypertension. Vessels, okay? If there is pulmonary embolism, that will cause congestion in the pulmonary circuit and hypertension in the systemic. Vasodilation, anaphylactic shock. In anaphylactic shock, chemicals that are released as the result of reaction will dilate the blood vessels, all of them in the entire body. Well, when all blood vessels are dilated, it's going to happen to blood pressure. It's going to tank, right? It's going to just, not just drop, it's going to tank. And it's really an awful thing. Hypovolemia can cause hypertension when you just don't have enough blood. Various structural diseases, especially valvular diseases of the valves, okay? And different types of arrhythmias when heart cannot pump properly. Does that make sense? Yes. Uh-huh. Yes. They can be. I don't really know why doctor goes. I mean, if one arm gives you 120/80 and another one gives you 180/110, then something is fundamentally wrong. Usually those numbers aren't that different. Does that make sense? They will probably go with the lower one just not to freak out the patient. That would be my best guess. I don't really know what they base the judgment on. Okay. Shock. Circulatory shock. The best description is when you don't have enough blood getting to the tissues. Does that make sense? That's what shock is. So, what can cause the shock? We're going to talk about the shock first, and then we're going to talk about response to the bleeding. So what can cause the shock? Rapid drop in blood pressure. Let's figure out what are three major factors that contribute to the blood pressure regulation. Okay, losing blood volume very quickly. Does that make sense? So huge blood loss, number one, and that's going to be hypovolemic shock. As far as I remember, the threshold for an average adult is 2 liters. So what happens when you lose a lot of blood, like 3 liters? What's going to happen to the blood pressure? It's going to go down. So what's going to happen to the blood flow to the tissues? Huh? Less blood goes to the tissues. Is heart a tissue? Yes. Low blood flow to the heart. How it's going to affect its contractile ability? Huh? It's going to slow down. If heart slows down, how it's going to affect the blood pressure? It's going to go down. When it goes down, the blood supply to the heart goes down, heart pumps slower, lower blood pressure, so it's a positive feedback. Okay? In case of, say, there's a patient in the field with hypovolemic shock, blood loss, what should be the first treatment? Say you stop, you stop the bleeding, but blood's gone. Blood? Fluid. You need fluid. All you need is to restore the pressure. Okay? Because you may not have actually blood somewhere outside of the hospital. Okay? So, in this case, and there were many studies that looked at the benefits of artificial blood over the regular isotonic solution, 0.9% sodium chloride. There's none. There's no benefit of artificial blood. You can just put isotonic solution, it will work just fine. It's not going to cure the person, but it will stabilize the person till he or she gets into the hospital. Does that make sense? Second, vascular shock. Blood vessels dilate, all of them. What's the word? Anaphylactic shock. It's the result of allergic reaction, systemic allergic reaction. The chemicals known as bradykinins and histamines will immediately dilate the blood vessels all over the place. Blood pressure drops, and then you go the same route. Blood supply to the heart decreases, contractility decreases, blood pressure drops, and so on and so forth. What is the treatment for anaphylactic shock? Epinephrine. Because you're not losing any blood. It's just the volume, the diameter, the resistance that went down. So you stick epinephrine, vessels constrict, heart starts to pump faster. Does that make sense? Third, cardiogenic. Heart doesn't pump, blood pressure goes down, heart cannot pump, it goes further down, heart cannot pump, it goes further down. Does that make sense? I wanted to mention something. Oh, sepsis. In sepsis is funny. I like sepsis. So what happens is, yes. Yeah, they will stimulate cardiac output as much as they can. Okay. In sepsis, what can happen is the fantastic condition that is called disseminated intravascular coagulation. That's a very interesting thing. Your blood starts to clot everywhere in the body. So blood flow is diminished severely. At the same time, those little clots, they take all the proteins out of the blood. So plasma starts to seep through the walls of the blood vessels, essentially decreasing the volume of the blood. So blood pressure tanks, and you have what can be considered as hypovolemic shock. So it's often a consequence of the systemic bacterial infection, the disseminated intravascular coagulation. There's a song with that name, by the way. I strongly do not recommend to Google it and listen to it because it's a rape to the ears. Now, response to the bleeding. Say you have a patient with an acute bleeding. I'm not talking about 1 pint that is taken when you donate blood. Say it's a liter and a half, considerable amount. Okay? So what's going to happen? Blood volume decreases, so the tissue perfusion becomes inadequate. It becomes low. You follow me? Okay? Second, tissue perfusion is low, oxygen levels in the tissues is low, metabolism becomes anaerobic. So pH goes down. Okay? In order to maintain the volume of the blood, okay, interstitial fluid from the tissues goes into the blood. So tissues start to dehydrate. What are the physiological responses? Acidic blood stimulates the respiratory centers. So you start to breathe faster. When you breathe faster, what do you exhale? Carbon dioxide. So essentially you exhale acid. You try to get rid of acid. Does that make sense? Heart is stimulated. So heart rate goes up. Perfusion of the tissues is low. By increasing the heart rate and contractility, you try to get away with a lower amount of blood by pumping it faster. Does that make sense? So tachycardia. When there is an sympathetic system is activated, it causes vasoconstriction. Now, vasoconstriction means the blood vessels are smaller. Are they smaller everywhere, or some organs are more important than others? Brain and heart. Two organs that are vital, right? Everything else can wait. So blood flow to the brain and heart remains unaltered. Blood flow to the skin goes down. Patient becomes pale. It also helps to spare some heat to increase metabolic rate. Okay? Renal blood flow goes down. So patient will have a decreased urine output. Does that make sense? That's via direct mechanism. Via indirect mechanism, renin will become released, stimulate aldosterone and retention of salt and water through kidneys. Patients will be thirsty, and decreased pH will depress the neuronal activity. First sign is restlessness, but over time, low pH causes coma. So essentially, if bleeding is stopped and patient has access to fluids, then the volume will be eventually restored and the patient will be fine. If bleeding is not stopped, then blood pressure will continue to lower and patient will go into the hypovolemic shock. Does that make sense? So stop the bleeding, restore the fluid volume. That make sense? That's why when you donate blood, they give you something to drink and they have it in the instruction, drink plenty of fluids in the next so and so hours to replenish, because you lose about 10% of your blood volume. Okay? So we're going to continue with the perfusion of tissues.